Can we get the sound for the video?
Hi everyone, I'm here to share my cardiac rehabilitation journey with you. After my myocardial infarction, cardiac rehabilitation was a key part of my recovery and helped me optimize my health. It addressed my perspectives, needs, and expectations. In my rehabilitation program, I met many different patients with cardiac conditions. Some also had frailty or other health problems. At the beginning, I went through a comprehensive assessment by a multidisciplinary team. I learned about different aspects of my health and completed several tests, examinations, and questionnaires. Based on this assessment, my rehabilitation program was personalized. It included exercise sessions, but also education and counseling on topics such as self-management, medication, nutrition, mental health, returning to work, and other activities. I appreciated that there were different ways to participate in cardiac rehabilitation. I chose to complete most of my program at the hospital, while other patients preferred combining hospital sessions with activities at home, supported by digital technologies. Cardiac rehabilitation can improve many outcomes. During my program, I learned how to live with my heart condition and how to manage it in the long term. Cardiac rehabilitation does more than reduce hospitalizations or improve survival. For me, it meant regaining my strength, feeling confident again, and returning to my normal life.
Dear Chairperson, dear ladies and gentlemen, dear colleagues and friends, for Maria, Dominique and me, it's a great privilege and pleasure to present the first European guidelines on cardiac rehabilitation throughout this conference. These are our declaration of interest. First and foremost, I really would like to thank our task force for their commitment and support. We were a great team with great diversity in terms of clinical background and also geographical distribution. And I would like to pick out two. That is Agnieszka Gombotsova and Roger Feldschub, our two patient representatives who always reminded us to keep the patient-centered approach. I would like to thank all the reviewers of our guideline, and I would like to thank the incredible ESC guideline team who supported us. And also, we would like to thank the ESC for choosing cardiac rehabilitation as a guideline topic, which will definitely help us to implement it further across Europe. Why does rehabilitation matter as a discipline? So societies worldwide are challenged by a widening health span, lifespan gap. Globally, people spend more than a decade in poor health, and this is even pronounced in Western countries. And rehabilitation is an evidence-based intervention that can reduce the morbidity gap. Cardiac rehabilitation comprises of different phases: prehabilitation, early rehabilitation during acute care, post-acute rehabilitation, and it extends into long-term support and health promotion. However, from a patient perspective, this is more perceived as a continuum of care, and within this continuum of care, the focus and the scope of our guideline is the structured and medically supervised phase 2 cardiac rehabilitation program, a personalized intervention designed to optimize the patient's physical, mental, and social functioning following a cardiac event or a diagnosis of cardiac disease. Cardiac rehabilitation is a complex intervention, and to facilitate implementation and adherence is important to align cardiac rehabilitation programs with patient goals, needs, and expectations through communication and collaborative care goal setting. And a shared decision-making approach is crucial for selecting the core components or the mode of delivery, and you will hear about this in a moment from Dominique and Maria. Cardiac rehabilitation needs a multi-dimensional assessment, and in addition to traditional outcome assessments like major adverse cardiovascular events, we emphasize the importance of patient-reported outcomes like symptoms, functional status, psychosocial status, quality of life, or health behaviors. So we recommend the assessment of patient-reported outcomes is recommended in all patients with an indication for cardiac rehabilitation to monitor disease progression, evaluate treatment outcomes, facilitate communication between patient and healthcare professionals, and to enhance shared decision-making. Given that this is difficult to reflect in randomized controlled trials, the level A was achieved by agreement of more than 90% of voting task force members. To structure care goal setting and also assessment, we recommend considering the WHO International Classification of Functioning, Disability and Health. This framework, grounded in the biopsychosocial model, describes functioning in different domains, starting with body functions and structures like exercise capacity, left ventricular function or geometry, extending into activities like handling stress and other psychological demands, lifting or carrying objects or driving, and ultimately leads in what gives lives a meaning in participation, relationship, work, and leisure time activities. These are influenced by other domains like environmental factors and personal factors. We had a little debate in our task force whether to include environmental stressors like climate or air pollution, and I think this heat wave in the summer proved us right to do so, to give recommendations. Given that cardiac rehabilitation has a very favorable benefit to harm ratio, early initiation of cardiac rehabilitation is recommended in patients with an indication to improve enrollment and functional outcome as early as possible. From a quality indicator perspective, this means after an acute coronary syndrome within the first 14 days, following a CABG surgery procedure within 28 days. Early initiation of cardiac rehabilitation should also be considered in patients hospitalized for decompensated heart failure to reduce in-hospital mortality. And it can begin shortly after achieving decongestion and hemodynamic stabilization once guideline-directed medical therapy has been initiated. And telemetry during exercise training in cardiac rehabilitation may be considered in selected patients, such as those at high NYHA functional classes, complex ventricular arrhythmias, critical remaining coronary stenosis, or comorbidities limiting exercise tolerance, to detect arrhythmias, ischemia, or abnormal hemodynamic responses, and to be able to start rehabilitation early. And now for the core components and for the delivery performance, I hand forward to my colleagues. Thank you very much.
Thank you very much. So this guideline covers a lot more than coronary artery disease or heart failure only. It covers a much broader spectrum of heart disease, including valvular congenital heart disease, atrial fibrillation, heart transplantation, and so on. And it's also explained in this guideline how to deal with patients with comorbidities, including frailty, diabetes, and so on and so on. And in the guideline, we explain what benefits can be expected as a result of cardiac rehabilitation. Sometimes we talk about prognosis, but sometimes we also talk about physical function or mental functioning. For example, in patients with acute and chronic coronary syndromes, cardiac rehabilitation is recommended to reduce the risk of cardiovascular mortality, myocardial infarction, and reduce all-cause hospitalization. On top of that, cardiac rehab is also recommended to improve physical functioning and health-related quality of life in these patients. In heart failure, the recommendations are slightly different. Here, cardiac rehab is recommended to reduce all-cause hospitalization admission and improve physical functioning and health-related quality of life, mainly in patients with HFrEF. And on top of that, rehab is also recommended in heart failure patients with advanced disease stages, also recipients of LVAD, and patients who have undergone heart transplantation. And also, cardiac rehab should be considered in patients with decompensated heart failure as soon as possible, if deemed medically safe, to improve physical functioning as well as health-related quality of life. For the other indications for cardiac rehab, we also provide our recommendations and our suggestions. And in this graph, the lower one is a very important one. Here we clearly state that cardiac rehab is not recommended to be withheld from patients with an indication for rehab because of frailty or comorbidities. So if you encounter patients with multiple comorbidities, that should not be the reason to withhold cardiac rehab from being implemented in the daily care of that individual. Now, the guideline also explains how the cardiac rehab should look like, and a good cardiac rehabilitation program or intervention all starts with a good baseline or intake assessment. And this assessment should be as comprehensive as possible. It's not only about clinical history, the execution of physical examinations and diagnostic tests. It should also involve the analysis or assessment of patient-reported outcome measures, including psychosocial factors. So you should screen for every aspect that could be touched by the heart disease in your patients. And once you have a good baseline assessment, that prepares you for a good rehabilitation program that can be personalized. And in cardiac rehab, we propose several core components that should be offered to our patients. It's not about pharmacotherapy and exercise training only. It should also involve nutritional and body composition management, smoking cessation, sexual counseling, and the management of frailty, comorbidities, and environmental factors, and also the implementation of interventions to improve or stimulate the return to work. And hereby I would like to give the word back to the next co-chair. Thank you very much.
Thank you. And digital health technologies provide an important adjunct to contemporary cardiac rehabilitation by supporting structured self-monitoring, personalized care, and improved patient engagement. Integrated telehealth consultations in patients with heart failure is supported by a Class 1, B1 recommendation, as this approach reduces short-term cardiovascular mortality and hospitalization. In addition, telehealth consultations should be considered to increase cardiac rehabilitation participation, adherence, and to achieve cardiac rehabilitation goals. AI methods for early detection of cardiovascular events and improved clinical decision-making, as well as to increase patient education, adherence, and cardiac rehabilitation goals, are assigned a Class 2B/C recommendation. Telemonitoring interventions, such as clinical self-monitoring sensors and smartphone applications, should be considered to better achieve cardiac rehabilitation goals. Clinical decision support systems should be considered for informed patient decisions and to help clinicians adhere with guidelines-directed therapy. Cardiac rehabilitation can be delivered through center-based programs at hospitals or community centers, or through home-based programs that are ideally digitally enhanced. Hybrid cardiac telerehabilitation combines elements of both. Despite the choice of delivery of cardiac rehabilitation, the full core components must be considered, as well as the program quality. The evidence supports all delivery modes. Center-based programs is a Class 1 recommendation. Cardiac telerehabilitation and hybrid cardiac telerehabilitation should be considered for most patient groups, while non-digitally enhanced home-based programs may be considered for selected low-risk patients. Selecting the mode of delivery of cardiac rehabilitation should involve shared decision-making, involving and taking into account the patient perspectives, the clinical needs, but also the available resources and infrastructure. Despite strong indications for cardiac rehabilitation, it remains substantially underused globally. Barriers to cardiac rehabilitation utilization occurs at different levels: the patient level, program, clinician, and health system level. To address these barriers, the guidelines highlight several actionable solutions. Endorsement of cardiac rehabilitation by the attending physician and other health professionals, automatic referral, receiving an invitation to attend an initial assessment, and increasing the availability of cardiac rehabilitation programs are all Class 1 recommendations for improving cardiac rehabilitation participation. This slide summarizes some of the key gaps in evidence that were identified during the development process of the guidelines. There is limited evidence on prehabilitation and on the routine use of PROMs, on the long-term comparative evidence and cost-effectiveness across cardiac rehabilitation delivery modes. There are still some under-researched cardiac rehabilitation indications and limited evidence on participation-enhancing interventions tailored to women and to cultural or socio-economic context. And there are poorly understood determinants of dropout and long-term non-adherence. This central illustration brings the guidelines together. It is recommended that cardiac rehabilitation should be delivered by a multidisciplinary team based on shared decision-making and on a comprehensive set of core components that should be individualized to the patient. There are different modes of delivery of cardiac rehabilitation, enhancing flexibility and personalization, and together these elements improve cardiac rehabilitation outcomes. And we would like to invite you to join our dedicated sessions on cardiac rehabilitation on Monday for more details. And we would also like you to invite you to sign up for the focus webinars on cardiac rehabilitation in September. And please download the guideline, read the guidelines, and use the guidelines in your clinical practice, and take the opportunity to interact with our task force members during this Congress. Thank you very much for the